Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. NIK NIKAM, and today we are going to learn something about carotid artery disease. So let's begin. Carotid artery disease is where there is buildup of an atherosclerotic plaque at the origin of the internal carotid artery. As you know, there are two carotid arteries that supply the right and the left side of the brain. They arise from the aortic arch. The main carotid artery divides into the internal carotid artery that supplies the brain inside the skull, while the external carotid artery supplies the skull and the structures outside the skull. So any occlusion at the origin of the carotid artery, which is the most common site, results in carotid artery disease. And here is an intracranial course of the internal carotid artery, one of the major branches of which is the middle cerebral artery that supplies the cerebral cortex or the motor area of the brain. And behind we have the vertebral arteries, which also arise from the aortic arch. They go through the vertebral bodies. It supplies the cerebellum and the posterior aspect of the brain hemispheres. Let's look at the incidence of a stroke, which is one of the features of a carotid artery disease with reference to age. The cerebrovascular diseases are related to the aging process of the individuals. As they get older, there is much higher incidence of cerebrovascular accidents, and more than 50% of them do have carotid artery disease. As we can see in the age group between 45 to 54, the incidence of stroke is 80 to 175 per 100,000 patient years, but that dramatically goes up in the 6th, 7th and 8th decades. As you can see, this is the overall stroke incidence, which is like 2,469 per 100,000 patient years in the age group 75 to 84, and it again exponentially goes up. And the interesting point here is the incidence of ischemic strokes, which are generally caused by carotid artery stenosis, also goes up much more significantly compared to the hemorrhagic stroke, which is represented here in the orange color. Then we have the unclassified, which forms a small percentage of the overall stroke incidence. Another important point about the incidence of carotid artery disease and stroke is that a majority of these patients are asymptomatic. Even when they have critical stenosis, they may be asymptomatic, but we need to determine the degree of stenosis along with other manifestations in order to decide if these patients need any type of surgical or percutaneous interventions. Let's look at some of the clinical features of carotid artery disease. The major risk factors for carotid artery disease are hypertension, diabetes, smoking, high cholesterol, and of course age, as we already saw in the epidemiology study, along with obesity and sedentary lifestyle. Of all these, hypertension and diabetes stand out significantly higher than the other risk factors. A person who has no history of hypertension and diabetes, if the relative risk of stroke is 1, as we add hypertension mild and moderate, the risk almost doubles, and if the patient has diabetes, the risk is almost 2.5 times that of the normal population. And when we combine severe hypertension and diabetes, their risk of stroke is 4 times that of the normal population. Here is an indication where controlling blood pressure and also controlling diabetes plays a significant role in reducing the overall incidence of a stroke in this population. When we are taking history in patients with suspected carotid artery disease, we need to focus on vascular risk factors, which we already looked at. We also need to look for focal neurological deficits, which we're going to talk in a minute, along with transient ocular changes. Some of these patients may also present with syncope, or very rarely present with a history of headache or neck pain. One of the hallmarks of carotid artery disease, by which we recognize carotid artery disease on clinical examination, is the carotid artery bruit. That is, when we put the stethoscope right at the bifurcation of the common carotid artery and firmly press it, we can hear the bruit if there is a stenosis of either the common carotid artery or the internal carotid artery. We can also hear a bruit if there is a stenosis of the external carotid artery. However, the presence of bruit does not signify the degree of carotid artery disease. Also, the absence of bruit does not totally exclude carotid artery stenosis. How is it possible? If the patient has a 99% stenosis of an internal carotid artery, the amount of blood going through that artery segment may be so small, we may not be able to hear a loud bruit. That is how the absence of a carotid artery bruit does not exclude carotid artery disease. Similarly, if a person has 100% occlusion of a carotid artery segment, then we are not going to hear any bruit whatsoever. Will the presence of carotid artery bruit change the investigation or disposition? Not necessarily. But nonetheless, in the age group we were talking about, who are at a higher risk of developing ischemic strokes, and majority of whom have carotid artery disease, we should always make it a point to listen to their carotid arteries on both sides. If we hear any type of bruit, then we need to proceed with further history evaluation to see if they have any unexplained symptoms of TIA, stroke, or hemispheric symptoms. Differential diagnosis of carotid bruit. All carotid bruits do not necessarily mean carotid artery disease, and all carotid artery disease do not necessarily have to produce a bruit. So things get just more and more complicated. Because if we have a patient with aortic stenosis, we are quite familiar with the conducted bruit that we hear from the stenotic aortic valve radiating into both the right and the left carotid arteries. Similarly, in elderly patients with very tortuous carotid arteries, it is not uncommon to hear carotid bruits. In patients with hyperdynamic heart, such as patients with hypertension or patients with anemia who have a systolic murmur at the aortic level because of a hyperdynamic state, may also have a bruit heard over the carotids. That doesn't necessarily mean they have functionally significant carotid artery disease. Now let's talk about the ischemic symptoms. We talked about the actual stenosis of the carotid artery. We talked about the carotid bruits. Now let's look at some indirect evidences for the presence of carotid artery stenosis before we proceed with any diagnostic test. Features of ocular ischemia or infarction include partial or complete blindness in one eye and an absent pupillary light risk. So if we are seeing a patient with disturbances in the vision, either partial loss or complete loss of vision, then we should always think about occlusion of the ophthalmic artery and look for any evidence of carotid artery disease. Similarly, hemispheric signs of infarction from carotid artery disease include contralateral homonymous hemianopsia, hemiparesis, and hemisensory loss. This is almost similar to TIA or a mini stroke, where the symptoms of visual problems along with paralysis, which may be transient. Specific signs of left hemispheric ischemia include aphasia, while the right hemispheric ischemia may manifest with visuospatial neglect or constructional apraxia. Sometimes these patients may present with atypical symptoms such as unilateral limb shaking, transient loss of monocular vision upon exposure to bright light, or sometimes they may present with syncope. Again, none of these symptoms are specific of carotid artery disease. Temporal arteritis may produce ocular symptoms that are similar to those we see in patients with carotid artery stenosis. Now let's talk a little bit about transient ischemic attacks or transient cerebrovascular accident. As you know, cerebrovascular accidents are the third cause of death in the United States. It's the number one disabling disease in America. 85% of the cerebrovascular accidents are due to ischemia from occlusion or stenosis. 15% of the cerebrovascular accidents are due to hemorrhage. TIA is an acute episode of focal loss of cerebral function, usually lasting less than 10 minutes. This definition is important to remember. After having a TIA, patients are at substantially increased risk for stroke occurring within the first 48 hours of the TIA. So, TIA is an important indicator of subsequent stroke risk, with 20 to 30% of the patients having a stroke over the ensuing 5 years. The symptoms are generally related to the vascular territories involved. Most often, ischemic events related to carotid artery stenosis will produce symptoms referable to middle cerebral artery territory, although the anterior cerebral artery can also be involved in some patients. Natural history of carotid artery disease. The risk of a stroke over 5 years among patients with asymptomatic stenosis was 8% for patients with less than 60% stenosis, 14% for those with stenosis ranging between 60 and 74%, 18.5% for those who have carotid artery stenosis ranging from 75 to 94%, and 14.7% for those with 95 to 99%. However, in patients with symptomatic stenosis, the risk of recurrent stroke on medical therapy is 5 to 7% per year for all strokes. So, there is a significant increase in risk of stroke based on the degree of stenosis, and by the same token, if the stenosis is less than 60%, the risk of stroke is considerably less compared to those with 75 to 90% stenosis. That is less than half. One more condition we need to talk before we go into the diagnostic test for carotid artery disease that involves amaurosis fugax. It's a Latin term for fleeting blindness. That means a transient blindness involving one or the other eye. It is a transient and complete unilateral loss of vision lasting seconds to minutes. It occurs suddenly and it is generally painless. The common causes of amaurosis fugax include carotid artery stenosis, heart valve disease where you can get a small emboli, cardiac arrhythmias, atrial or ventricular thrombus, and it is an important precursor for stroke. Anytime patients with amaurosis fugax present, we should always do a complete evaluation to make sure we are not dealing with treatable causes. Patients with amaurosis fugax may have bright spots on their ophthalmic examination, and which are called Hollenhorst intravascular plaques. Now let's look at some diagnostic tests. There are 4 main diagnostic tests that are available to diagnose and determine the degree of carotid artery stenosis. They include the non-invasive carotid duplex ultrasound. Then we have computed tomography or CT angiography. We also have magnetic resonance angiography, and finally catheter-based cerebral angiography. Let's look at the merits of each one of these tests. Carotid duplex ultrasound. This is a simple procedure which can be done in an office setup during the first visit. It is non-invasive. It is virtually without any complications. It is readily available, and it has a sensitivity of 70% when compared with the angiography. But this is a great screening tool to look for the presence or absence of carotid artery disease, and also look at the degree of stenosis based on the velocities, which will complement some of the findings we see on CT angiography or MR angiogram when we are not very clear as to the degree of stenosis. First, we need to determine the degree of carotid artery stenosis, because that determines the selection for medical or surgical treatment, and it also is helpful in projecting prognosis. Sometimes with other modalities we may not be able to clearly delineate the degree of stenosis. However, the ultrasound velocities can complement the missing part in determining the degree of functional stenosis in patients with carotid artery disease. CT angiography, it involves IV contrast and complications related to large doses of IV contrast, but it has very good resolution. But at the same time, it requires a specially trained radiologist to interpret these studies. This should be available in most institutions, but getting qualified people to read them could be a challenge, especially in the nights and on weekends. MR angiogram has similarities compared to CT angiography. It also has good resolution, but it requires a more specialized radiologist to interpret these studies. Again, they may not be available in every institution. One of the major problems that we face when we are considering MR angiogram is claustrophobia. A fair number of people may have claustrophobia going through that small donut, and they need to be pre-treated with tranquilizers. And another important thing is that the patients have to remain still for 20 to 30 minutes, whereas CT angiography may just take a few minutes for completion once all the setup is done. Digital subtraction angiography, of course, this involves putting catheters into the aorta and then advancing them into the common carotid arteries, then taking pictures of the neck before and after the contrast injection. Then we subtract the baseline image to get just the angiograms of the carotid arteries, which helps us to very clearly delineate the degree of stenosis, the location, and the status of the arteries beyond the blockage. It is a gold standard as far as diagnosing carotid artery stenosis, but it is an invasive procedure. We have the problems related to the IV contrast, and there is also a 1% risk of stroke. Which test should we order? Of course, everyone gets the ultrasound test, and I strongly recommend we should get ultrasound tests not only for screening purpose, but also to look at the velocities, which can be very, very useful when we have questionable stenosis in the internal or the common carotid arteries. CTA is performed in lieu of MRA if there is contraindication to MRA imaging, like patients who may have pacemakers or metallic objects in their chest and neck, and they may not be able to go through MRA, so they can undergo CTA. Conventional angiography is rarely performed, and it may be indicated in patients who cannot tolerate MRA or who cannot receive large doses of contrast because of kidney problems. However, conventional angiography may be useful, especially if we are also considering percutaneous intervention or stent placement in the carotid artery if there is a critical blockage. This is how a carotid duplex scan is performed. A jelly is placed over the transducer, and the transducer is placed right at the bifurcation of the common carotid artery into the internal and the external carotid arteries, and we obtain ultrasound images looking at the actual anatomy of the common carotid artery, the internal carotid artery. And here's an example of an ultrasound of the carotid artery at its bifurcation. As we can see, here's the common carotid artery, here's the intimal layer, here we have the bulb, carotid bulb, this is the internal carotid artery, this is the external carotid artery. If we are not sure what each one of these branches represent, the pulse wave velocity and the format will help us to identify the internal versus the external carotid artery. Now here is a cross section of the carotid artery. where the transducer is held 90 degrees to the long axis of the carotid artery. So we get the short axis of the carotid artery. As you can see, we have a buildup of a plaque here in the carotid artery. In addition to getting the anatomical view of the carotid artery, we can also use color Doppler along with velocity measurements that will help us to look at the pattern of blood flow across these arteries, especially when they are stenotic, along with the velocity waveforms, which helps us to identify whether the velocity is normal, which means the blood flow is normal, or if the velocity is high, which may indicate a certain degree of stenosis. Talking about stenosis, the normal velocity is less than 125 centimeters per second. If the velocity goes above 125 centimeters per second, then we are looking at 50 to 79% stenosis. If the end diastolic velocity is greater than 140 centimeters per second, then we are looking at 80 to 99% stenosis of the carotid artery. And we also look at the ratio of internal carotid artery to common carotid artery. If this ratio is greater than 4, it indicates greater than 70% stenosis of the carotid artery. And we should always remember, if there is a total occlusion of the carotid artery, there may be absence of flow and we may not see appreciable velocity waves as such. With a contralateral internal carotid artery occlusion, the internal carotid artery flow velocity may be falsely elevated. Other important points we need to keep in mind is the extent of the plaque characteristics, and patency of the distal internal carotid artery. Now, here's an example of probably a patient with atrial fibrillation, because we have varying velocity heights. But nonetheless, here the probe is in the internal carotid artery. We are doing a pulse wave recording. As you can see, the normal is this is 1 centimeter, this is 1 meter, so the normal should be 1.25 meters, and here the velocity is almost peak systolic velocity is 426 centimeters per second, or 4.25 meters per second. So this is indicative of greater than 90% stenosis of the carotid artery. Then in the next example, we are looking not only of the systolic velocity, which is of a range of 255 centimeters per second, but if you look at the diastolic velocity, anytime the diastolic velocity is greater than 40 centimeters, it is significant, and here it is almost greater than 100 centimeters. That means this is indicative of greater than 90% stenosis of the carotid artery. As you can also see by the ultrasound, the tapering of this color flow Doppler, and there is mosaic pattern, that is a multi-color pattern suggestive of post-stenotic turbulence. This is an example of significantly critical carotid artery stenosis. Here's another example where we have a velocity which is like 5 meters per second, along with the diastolic velocity which is like almost 200 centimeters or 2 meters. This is another example of critical stenosis of an internal carotid artery, and the waveform suggests that this is internal carotid artery. When is ultrasound not reliable? If we have severe calcific arteries, velocities may be increased, just as we see in patients with peripheral arterial disease who have highly calcified fixed vessels, whose ankle brachial ratio can be greater than 1.40. Similarly, severe calcific arteries can produce high velocities without any evidence of critical stenosis. Severe kinking in the vessels, extreme tortuosity, and multiple kinks can cause similar changes in velocities. Short neck may also be difficult in patients with short neck, where the bifurcation may be hidden behind the jaw. It may be difficult to image those patients, and that's what I was talking about, high bifurcation. Here is anatomy of cerebral circulation. Let's spend a couple of minutes here, and in that way we understand when we look at MRA, CT and angiograms. Here we have the aortic arch, which gives rise to the innominate artery, which divides into the right subclavian and the right common carotid artery. The right common carotid artery divides into the right internal carotid artery, which supplies inside the brain, and the right external carotid artery, which is characterized by multiple branches. It supplies outside the skull. And then we have the vertebral artery, which goes posteriorly through the vertebral bodies, and all these branches join together here at the base of the brain. On the left side, of course, we have the left common carotid artery arising directly from the aortic arch. It divides again into the internal carotid artery, which goes inside the brain. Then we have the external carotid artery supplying the outside of the skull and structures surrounding that. Then we have the subclavian artery coming from the left side, which gives rise to the left vertebral artery, and all these four branches join here at the circle of Willis. If you look at angiography, here we have the aortic arch, here is the innominate artery and the subclavian going, and here is this is the external carotid artery, which has side branches, as you can see, whereas the internal carotid artery is probably blocked off. And then on the left side we have the left common carotid artery, which has a critical stenosis involving the internal carotid branch. Here is a different example showing almost complete occlusion of the common carotid artery from what we can see in this image. All right, let's move on here. We have similar situation here. We have the right innominate subclavian and the common carotid, and here's the artery going inside, which has a critical stenosis, and there's also critical stenosis involving the left carotid artery also. Here is an CT angiography showing a much better view of the common carotid artery, the external carotid. The difference between the external carotid artery and the internal carotid artery is the branches, side branches coming from the external carotid artery, whereas the internal carotid artery has no branches until it enters the skull. So there is a critical stenosis at the origin of internal carotid artery. And here's a digital subtraction image, which is showing a critical stenosis involving the internal carotid artery. As I told you, they have no branches until they get inside the brain. And here is an image showing after the placement of a carotid stent. Difference between CTA and digital subtraction angiography. There is a very good correlation between CT angiography and digital subtraction angiography. However, digital subtraction angiography has a sensitivity of 100% and a specificity of 63% with a negative predictive value which is 100%. So this is an extremely useful test, especially even in patients in whom we may have questions after CT angiography. Like here's an example of an angiogram where it is very hard to say how critical the stenosis is, but a digital subtraction angiography can show you the nature of the stenosis in this particular region. Okay, let's talk about management of carotid artery disease. Why do we have to treat carotid artery disease? The risk of a stroke over 5 years among patients with asymptomatic stenosis, we went over this one just again 8% for those who have less than 60% stenosis. It's 14% among those who have lesions between 60 to 74%. It jumps up to 18.5% if they have a lesion ranging from 75 to 94%, and it drops a little bit for those with 95 to 99% stenosis because they may have already developed some collaterals from the other side. Now, there are two main options available, namely medical and surgical, and in the surgical group we have coronary stent placement or carotid endarterectomy, but nonetheless all patients should undergo medical treatment whether they get surgical treatment or not. So we should optimize their risk factors by treating them with aspirin or clopidogrel. They should all be maintained on lipid-lowering drug. And I talked about the importance of hypertension in patients with stroke and carotid artery disease. So all patients with hypertension should receive good control of their blood pressure, which can reduce the risk of stroke by almost 60%. Now let's talk about this medical treatment. Hypertension, of course, the goal is to reduce the blood pressure below 140 over 90 millimeters of mercury. However, if you are dealing with a patient with diabetes, the goal should be 130 over 85. Use of ACE inhibitors should be encouraged in these patients. If the patients have diabetes, the fasting blood sugar goal should be less than 126 milligram per deciliter. Again, the LDL goal should be 100. They should be absolutely advised about smoking cessation, elimination of excess alcohol, and physical activity, as we would normally recommend to any patients with any type of cardiovascular disease, hypertension, or diabetes. Now let's talk about carotid artery revascularization indications. If there's no significant carotid artery stenosis, they are going on medical treatment. If carotid revascularization is indicated based on the criteria we talked about, those patients who have greater than 75% or 70% stenosis with symptoms. Remember, we need to underscore the statement: symptomatic carotid artery patients with greater than 70% stenosis. Then we evaluate them for carotid artery stent risk. If the risk for carotid stent placement is low, they undergo carotid stenting. If this risk of carotid artery stenting is very high due to technical problems or very tortuous vessels, then carotid endarterectomy should be evaluated. If the carotid endarterectomy risk is low, these patients undergo carotid endarterectomy. If we are talking about an advanced patient with multi-system problems and poor prognosis, then they should be considered for medical treatment. Now let's talk about carotid stenting. Carotid stenting is a procedure wherein a guide wire is introduced from the groin and it is passed through the common carotid artery and into the internal carotid artery. Once the guide wire is in place, first a balloon is used to compress the plaque. After the compression of the plaque, a self-expanding stent is introduced at the site of the blockage, and when the procedure is done, we have an expanded stent which plasters to the arterial wall, thus increasing the internal carotid artery lumen. Some of the risks that we need to be concerned about when we are considering carotid artery stenting include stroke, heart attack, bleeding, damage to blood vessels, infection, restenosis, and death. Of course, the benefit is the reduction of a stroke that may result from critical carotid artery stenosis. Now, here's an example of a critical stenosis of the internal carotid artery at its bifurcation, and here is the end result after placement of a carotid artery stent. Similarly, we have another example here where we see a critical stenosis. Of course, this is after the origin of the internal carotid artery, and here is a stent placed right almost at the origin of the internal carotid artery, and it has very nicely opened up the lumen, thus reducing the blockage and improving the carotid circulation. Let's talk about carotid artery surgery. Which patient is a candidate for carotid artery surgery, and what do we do in carotid artery surgery? First of all, carotid artery surgery is indicated for patients with symptomatic carotid stenosis. So let us underline the word symptomatic carotid artery stenosis. If the person has a symptomatic carotid artery stenosis of greater than 70%, the rate of ipsilateral stroke is 26% in the medical group versus 9% in the surgical group. So there is clear-cut indication that by performing carotid endarterectomy in symptomatic patients with carotid artery stenosis having greater than 70% stenosis, we can dramatically reduce the incidence of stroke. The relative risk reduction is 65% and the absolute risk reduction is 17%. This is a class 1 indication for performing carotid artery surgery in patients with symptomatic carotid artery disease with greater than 70% stenosis. However, if we have a symptomatic patient with carotid artery stenosis and less than 50% stenosis, there is no evidence that these patients benefit from carotid artery surgery. So, if you are dealing with a patient who is having symptoms but less than 50% stenosis, they need to be treated aggressively using medications to reduce the risk factors, namely aspirin or Plavix, along with adequate control of blood pressure, lipids and diabetes. Let's talk about symptomatic patients with moderate stenosis between 50 to 69%. Again, there was no significant benefit of surgery for those with moderate stenosis. When they looked at the 5-year risk of a fatal or non-fatal ipsilateral stroke among patients in this group, it was 22% in the medically treated group compared to 15% in the surgical group. The absolute risk reduction was 6.5%. So there was no dramatic benefit in this group. Let's talk about asymptomatic patients with greater than 60% stenosis. The risk of ipsilateral stroke or any perioperative stroke or death was 5% during the 5-year follow-up in surgically treated patients and 11% in the medically treated patient. The absolute risk reduction was 6%. Because of the lower absolute risk reduction, a rate of perioperative complications, which including stroke or death of more than 3%, that would eliminate the potential benefit of the carotid endarterectomy surgery. However, the benefit of surgery was greater for men than for women. Risk reduction among men was 66% versus 17% in women. We have to be very selective when we are dealing with asymptomatic patients with greater than 60% stenosis when we decide whether they need medical or surgical treatment. Let's talk about carotid artery treatment in women. If women have greater than 70% stenosis, we are talking about symptomatic patients. The 5-year absolute risk reduction in stroke from carotid endarterectomy was similar between women and men. The 30-day perioperative risk of death was higher in women than in men, 2.3 versus 0.8%. The risk of stroke was similar compared to men. However, there was a significantly higher perioperative mortality. The higher perioperative risk of stroke and death was also observed in women, but it was not statistically significant, namely 7.6% versus 5.9%. Now let's talk about women with symptomatic disease who have 50 to 69% stenosis. Carotid endarterectomy was not beneficial in women. Risk reduction, that was only 3%, contrary to men in whom the absolute risk reduction was 10%. These patients should be treated medically, and in fact, people who were treated medically had lower risk of stroke. From a surgical technical point of view, an incision is placed in the neck. The arteries are opened up here, and after the opening of the artery, the plaque is removed, scraped from the arterial wall, and these arteries are clamped so the debris doesn't get into the cerebral circulation. After the plaque is removed and the artery is cleaned and washed, usually a Dacron patch is placed to increase the size of the lumen, and the arterial walls are sutured together. That's how a carotid endarterectomy is performed. And here is an actual surgical specimen showing the carotid artery, and as you can see, a very tortuous carotid, internal carotid artery. And when we see something like this, we need to be very aware of the fact that the ultrasound velocities could be misleading, and also angiograms can be sometimes misleading because of these kinks. And here we have a plaque which is scraped off from the artery. Then generally a Dacron graft is placed and sutured, which improves the lumen size and thus decreases the carotid artery stenosis. Prognosis. Let's talk about prognosis. The incidence of a peri-procedural 30-day outcomes weighted average. The risk of stroke among patients undergoing endarterectomy, stenting. Stroke or death was 5.4% with endarterectomy, and stenting was 7.3%. It was, if you just look at stroke alone, the risk of stroke was 4.2% in the endarterectomy, whereas in stenting it was 5.7%, which barely was statistically significant. Death rate is not much different. Disabling stroke or death, they were similar, not significant. Myocardial infarction was 2.6% in patients undergoing endarterectomy compared to those undergoing stent placement, and it was significant. Cranial nerve injury was seen in 7.5% of patients undergoing endarterectomy because of meddling around the carotid artery itself, whereas it was rarely seen in patients with stenting. So there are some advantages of doing endarterectomy compared to stenting, but the overall results is sort of very much. Now here are several studies that looked at the comparison between carotid and percentage restenosis in these populations. The CAROTID study looked at 50 patients. The restenosis rate was 16% in patients who had carotid artery stenting versus 10% who had endarterectomy. In the SAPPHIRE study, the restenosis was 3%, whereas in patients with carotid endarterectomy it was 7.1%. Whereas EVA 3S study, the incidence was 3.3 versus 2.8. In the CREST study, incidence of restenosis were almost similar. The CREST is probably the most recent study, and we had the SPACE study which had 5, and CREST is the most recent study and it has the most number of patients. So this suggests that carotid artery stenting and carotid artery endarterectomy have almost similar restenosis rates. And here's one more study, SPACE, which looked at 500 plus patients, which is a fairly large number. The incidence of restenosis in the stent patients was almost twice that you see in patients with carotid artery endarterectomy. Here are some prospective trials looking at carotid endarterectomy versus medical therapy. The ECST looked at a 3-year follow-up. In the surgical arm, the risk of stroke was 2.8%, whereas in the medical arm it was 16.8%. In the NSET study, it was 2.7-year follow-up, 9% in the surgical arm versus 26%. And similarly, VACS study looked at almost 12-month study looked at a 12-month outcome. In the surgical arm, the risk of stroke was 7.9% versus 25%. So there is clear-cut indications in symptomatic patients with carotid artery stenosis with greater than 70% stenosis. There is a dramatic benefit by considering these patients for carotid endarterectomy or carotid artery stent placement. This is an overview of carotid artery disease, its clinical manifestations, diagnostic tests, and management. Thank you so much for watching this video, and we will see you next time. I am Dr. NIK NIKAM.